Hello and welcome back to Beyond Sound, where we sit down with some of the world's leading minds in hearing health to explore the ideas, technologies, and collaborations shaping the future of hearing care. If this is your first time listening, Beyond Sound is produced by the Hearing Group, an international network of top hearing implant centers working together to turn cutting-edge research and clinical expertise into real-world impact. Today's episode, number 5 in the series, takes us into the world of robotic and technology-assisted cochlear implant surgery, an area that's moving fast and raising important clinical questions along the way. We're delighted to welcome Professor Vedat Topsakal, who brings a sharp and thoughtful perspective on robotics and otology. In this session, he traces how robotic assistance has evolved, highlighting key themes like precision, safety, and standardization. On top of that, we'll also have a chance to hear more about technologies such as HEARO, OtoPlan, and OtoDrive. Following his presentation, you'll hear a lively expert discussion with Professor Miller, Professor Baumgartner, Professor Ruck, and Professor Caversacho, as they unpack what robotic surgery looks like in real clinical practice, from workflows and patient selection to automation, collaboration, and what lies ahead. If you're not driving, we recommend checking out our slides in the video to get even more out of this session. And with this, settle in, and please, Professor Topsakal, the microphone is yours.
Thank you so much. It's a privilege to be on this panel with all pioneers and people performing HEARO and all robotics surgery. It's a group of very, let's say, highly experienced surgeons. It's a quest, and in this quest, I always find myself defining definitions. So I want to take you back a little bit in the next 5 minutes to semantics and what we do. Semantics, what is a robot? On the left side, you see a device already patented in 1932 by Molinex, and in Dutch, it's called a kitchen robot. It actually cuts in a very standardized way your vegetables. And that's one of the goals. We want to standardize our CI outcomes. But in between, since 2015, people are working on a real kitchen robot. You see 2 robotic arms, you push a button that says spaghetti, and it makes you spaghetti. So what's the difference? Well, what's the difference? We need to be careful on how we define the procedures that we are performing with these highly technological tools. And then you go to the definition of what is a robot. A robot is a machine. It's technology that's providing this machine, but it's programmable. If it's not programmable and if it's steered in a master-slave way by the surgeon, no, it's preferably programmable by a computer and executes a complex series of actions, not only one action. And it does that automatically. The word comes from a play from Karel Čapek's. I invite you all to put into ChatGPT what is then robotics, what is then robot-assisted. Very interesting definitions. And I know for sure a robotologist will be a definition in the future, but we will have to see. So you've nicely shown, Professor Baumgartner, thank you for this, the HEARO system. The HEARO system is a whole set of tools aiming for one target. It's the highest precision in keyhole surgery for cochlear implantation. And it did not come overnight. I would like to go to the next slide. It came through the pioneering work also mentioned here, and we cannot mention it often enough, by Professor Caversacho and his team in Bern, Switzerland, because they were courageous enough to go with a 1.8 cutting drill to the facial recess. And this at that time was some courage, but it was based on science and it was based on calculations with the whole team and setup. When we started in Belgium, I discussed a lot with him, and he always focused on safety, safety, safety. If there is no safety and you have a facial nerve, the whole program will probably not continue. So we picked up on his work with middle ear. We worked with newer, let's say, updated devices as the HEARO system was at that moment, to the inner ear access. And then OtoPlan was also booming as a standalone product, where it was designed as the programming software dedicated to HEARO. It's also available on the market now as an otological tool. Insertion angles can become important. I have not accepted a, let's say, not full insertion of cochlear implantation in a conventional way since we do auto-planning. Cochlear duct length became important. I came up with canostomy, anatomy-based fitting. The post-op images is now in discussion and under research. The system got CE marked, as already nicely demonstrated. More than 6 countries are doing now HEARO. And as we continue along, also mentioned before, the navigation is the highest accuracy in healthcare. Imagine if we can share that with neurosurgical procedures. OtoDrive gives you yet another set of tools added to the system, or addable to the system, but also as a standalone available, that standardizes the insertion of speed. If you want, it also is the maximum control of pressure changes in inner ear fluids. So it's a minimalization of trauma to the inner ear. And that's what we want to pursue in actually our quest towards minimal invasive cochlear implant surgery. Here you see the device as a standalone. And first of all, we tried it, of course, in a conventional case where we did a conventional mastectomy, posterior tympanotomy. And you see you have both of your hands free. You can manipulate the round window membrane as you do conventionally. If anything I can say about this device, it's its usability. It does not give you any hurdle in your conventional surgery. Of course, you have to steer it. You have to direct in which way the insertion is being performed. And therefore, you have to do it manually with the Otto arm aligner. It's not so difficult, but yeah, that's where actually HEARO's works was coming from firstly. So imagine you do this and then the insertion is child's play because the insertion with flex electrodes, well, if the tip goes in, everybody doing flex electrodes knows that the rest is a matter of patience. And in here you see an insertion being performed at a speed of 0.1 millimeter per second. It's all debatable what is the ideal speed, but it's available. The technology is supplying this. So here also OtoPlan features of 5.0, a post-op image showing it already in the right scala. The scala tympani is now colored and outlined specifically for you for your insertion depth. Imagine we combine HEARO with OtoDrive. In the correct word, we would have a CI robot that does it from the whole beginning towards the whole end. And imagine this is also put out and put forward by Professor Cavarsaccio that we did not come up with this overnight. We had to study middle ear access. We had to study inner ear access. We had to align perfectly the middle ear and inner ear access just to be able to do the true keyhole procedure, as you mentioned before. And then OtoDrive can do the insertion in the correct alignment. All these steps and hurdles was taken. And one more thing I want to point out. HEARO 4.0 already OtoPlan, but 5.0 as well, is giving you the automated segmentation of the individual anatomy. It's giving you a suggestion. This would be the ideal drilling trajectory in the terms that we define it currently. So yes, we are pursuing higher levels of autonomy with HEARO with this. I would dare to say we're going towards level A4 of robotics. Putting that aside, and to sum up, here you see our first case that we did a drilling trajectory with the HEARO, and then we used actually the OtoDrive to do the insertion in the first case of our series in Belgium. Having said that, I can also confirm this was a full insertion with the OtoPlan post-op imagings. And I would like to conclude with, let's point out why we are doing this. It's clear that the accuracy and the precision of this device is something we like in otology, and the system provides it at the best in healthcare possibly available today. Repeatability is something that we want to standardize the outcomes. Reliability, you have shown, Professor Baumgartner, an anomaly. We did also a couple of cases with challenging abnormal anatomies, and the system provides all the time that what you program it to do. So it's very reliable. We have some studies now on noise exposure. We say we do no mastodectomy, but we have to prove what's the use of it. So it really has less noise exposure as well. So probably it is paving the way towards, let's say, the maximum minimalization of trauma and electroacoustic stimulation, perhaps in the ear, but for sure, it's going to standardize the CI outcomes. As I said, since we are doing robotics, also in our conventional surgery, we don't accept incomplete insertions anymore as a successful CI surgery. So it's already improving in conventional surgery, the quality and the outcomes for our patients. And as you also said, if this becomes, let's say, standard, the surgeon is pointing towards the future and we don't need to do anything anymore. I would like to thank you for your attention and I'm open for questions.
Professor Topsakal, thank you very much for this great talk. And it's really outstanding. It's the very first time that I did see both auto-arm, auto-drive procedures live in a surgery, also with the HEARO. So really congratulations. So are there any remarks or questions from our group or from the audience? So then I will ask, is there one? Yeah, Marco, please.
What is the team? You know, we have seen is a paradigm shift in the last years. 20 years ago was one man, one goal. Today is the question, how many people you need for making an operation? What is the standard at the moment in Brussels? Is how many people are involved, because also for the cost, etc. You can tell us a little bit what is your team, the peers, the control in Brussels now? Yeah,
I immediately have to admit I have not succeeded doing a HEARO procedure on my own from A to Z. It's not possible. That's a correct and honest answer to your question. I also have to admit that the first case, I think all of the engineers of Kessel Nation were present, but you have to have a brain team or thinking decisive team, and I've always involved and invited engineers into that. I've taken radio protection courses myself, so I am able to use the XCAT on my own. But I have to say it's convenient if somebody else does that, because you're focused on so many things, so you cannot be focusing on the highest level of imaging. So there is a whole team behind it. In terms of, let's say, the nurses, we don't need to forget that everybody needs training when we use this device, but they all accepted it very well. They've been trained, let's say, a week before, and they could perform. And they've been asking questions which were very valid. Can we not, win time if we do this or this? And I have to say, in the beginning, the time was no issue. Our first case was 6.5 hours. Our latest cases are around 2 and 3 hours, maybe. We can do 2 HEAROs in one day. But the paradigm shift, I think that's, insights in gaining knowledge. I have to say, in the beginning, we were quite, let's say, flexible on screenings. If the facial recess was big enough, we say, okay, let's go for HEARO. But we were opening the tympanomeatal flap, and there was some room to manipulate the electrode if we did not have a swift line. Today, we are also screening, I have to say, a bit more stringently. There where we screened 10 patients and we could do 8 in the beginning. Now we screen rather 10 patients and we can do 2 or 3, because we take into account the orientation of the round window membrane. And we say, okay, but maybe this case is a bit challenging, and so on and so on. So these are, let's say, we are gaining more and more insight on this.
Thank you very much.
I maybe have a question regarding this OtoDrive.
Of course, I'm listening.
Yeah. So which speed did you use? Did you use always the minimum speed, or is there a possibility to change it? Or does it make sense to have change the speed during insertion time?
Yes, this is a very good question. And this is also something we need to research actually all together. We use the lowest speed, which is 0.1 millimeter per second, but you can change it. And you can also, let's say, stop the insertion. And since it's a tunnel, and since it's actually a robotic setup with a head clamp, it will not move, and you can decide. So imagine I did a couple of electrocochleographies conventionally, And then suddenly an engineer says, stop, I lose a signal. What do you want to do? You stop, but you cannot hold that position for a long time, and then you have to quickly decide what to do. I also witnessed this, let's say, with OtoDrive. You have to be careful if you use OtoDrive in a conventional way that you don't have an anesthesiologist leaning against your operating bed, but it moves, or you do it yourself by accident sometimes, or your resident. So these are very interesting things that we need to work out. What is the correct insertion speed? What can we learn from electrocochleography signals if there is residual hearing in that individual ear? And what are the algorithms that we have to come up with? Thank you so much for this question. And the honesty is, I don't know the answer.
Vedat, how much was the additional work to mount the Otto arm on the already existing HEARO system?
I have to admit also we did a little cheat because OtoDrive is CE marked, so we used actually an arm to use the tunnel that HEARO did. So this is something under development, but it was not a big burden to do so. It's actually the same way as you would do it conventionally. So it's not a big burden, but for sure it is something I pursue to develop further on, together with the whole engineering team and minds behind this, let's say, product.
Yeah, great, thank you.
And that brings us to the end of today's episode of Beyond Sound. We hope this session offered valuable insights into the evolving role of robotics and automation in cochlear implant surgery, and how precision, safety, and multidisciplinary collaboration are shaping the future of hearing restoration. Big thank you goes to our host, Professor Vedat Topsakal, and our esteemed panel, including Professor Müller, Professor Baumgartner, Professor Rack, and Professor Keversaccio. If today's conversation sparked your interest, don't forget to visit boost.hearing.com. Hearing's educational platform featuring masterclasses, symposia, and expert-led courses that dive even deeper into these topics. Make sure to subscribe to Beyond Sound on Spotify or YouTube, or both, so you won't miss upcoming episodes exploring the science, technology, and clinical innovations behind hearing care. And of course, stay connected with the hearing community. You can follow us on LinkedIn, Instagram, YouTube, and Facebook at Hearing Group. Thank you for listening, and until next time, keep going beyond sound.